I'd like to now pivot to a tremendous panel that we've put together of inspiring leaders who are trying to drive health equity from the lens of very different sectors. Moderating this panel will be Andre Blackman, founder and CEO of Onboard Health. Lauren Powell will be joining him on the panel. Lauren is Vice President of U.S. Health Equity and Community Wellness at Takeda Pharmaceuticals. Ivor Horn is Director of Health Equity and Product Inclusion at Google. And Toya Nyagi is Chief Health Officer and co-founder at Cityblock Health. Through the lens of these tremendous leaders, you'll hear pharmaceutical, technology, as well as healthcare delivery perspectives on issues related to health equity. And really thrilled that they've agreed to join us. And I will now turn it over to Andre, who will moderate the panel.
Fantastic. Thank you so very much, Sachin. Hello, everyone. Really excited to be here and have this opportunity alongside of this amazing panel of pioneering leaders today to discuss the pressing issue of health equity. I think we can all agree that now more than ever is absolutely critical to building the future, particularly as it relates to health. So without any further ado, let's dive on in and really kind of get some insight on what we can do and what we need to have right now in order to make this an effective year. So for Dr. Powell, I'll kick off this first question, and then obviously this is open to each and every one of you. So obviously identifying relevant tools and context is usually the first step to make better decisions. And so coming out of last year and all the things that we have going on right now, what do we actually need for this work that we're doing in the space of confronting and creating solutions around health inequities?
Yeah, well, thanks for that question. First, just let me say good morning, and it's great to join you on this panel, and thanks to Academy Health for putting this together. I think there are a couple tools we need. One, I think, we need the diverse sort of researchers. We need folks with an inclusive lens to help us do this data collection and to also analyze our data. We need to ensure that we have the technology. We saw very early on in the pandemic, some of the sort of delayed response of our public health systems was because of the lack of infrastructure and technology to be able to move swiftly. So I think we absolutely have to have technology. But when I think about the most important tool, I really think it's about the framework in which we approach data collection, analysis, and reporting. So I think first and foremost, the most important foundation of that is that we have a framing that elevates equity, and we have a framing that elevates the need for anti-racist practices in both collecting data, analyzing it, and then how we share it with the public.
Fantastic. Having a framework to build from and having this kind of uniform way to actually interpret and understand things is absolutely critical. Dr. Horn, so apart from, kind of building this framework and kind of moving forward on what else we need, it's obviously not just about having more data. Could you add some insight from your perspective on what kind of, kind of frameworks of mind that we need to have as we build out this kind of work? Not sure if we can hear you right now, Dr. Horn. I'm not sure. Are you on mute? Okay, I think that Dr. Horn is on mute right now. We can't really hear her. And so, Dr. Powell, could you just kind of explain a little bit more about this kind of framework and why it's so important to have this kind of, alignment on, beginning on what kind of tools that we need and the frameworks around health equity is kind of defining it across the board?
Yeah, sure. Well, I think a framework of health equity first centers the fact that there are populations that have been marginalized due to historic oppression and injustice, and that it's important in our data collection and in our data analysis and even how we talk about these communities that we uplift the systemic structures and the systemic barriers, systemic barriers and challenges that have really contributed to some of the outcomes that we see today. So I think that's important. I think it's also important that, we're not only focusing on quantitative data, but we're also focusing on qualitative data, that it's just as important to be able to uplift the voices of people with lived experience as it is to be able to quantify their experience with quantitative data.
Absolutely. And so I want to pass this over to Dr. Ajayi as well to chime in on what we need from her perspective and lens as well.
Great, thank you. So I really appreciate the framing, Dr. Powell. That's really helpful. I think, we are at a moment in time when we're just starting to care in many ways, to quantify and to measure and to ask for accountability on metrics of equity. So that's a good first step, right? I've always believed that you measure what matters, and we can take action with data. And so that's great. I think the next piece though for us is then how do you take action on that data, right? And what we know is that when we start to measure in just about every metric you can imagine that matters to health and well-being, communities that have been historically marginalized fare worse. And when you experience a massive, massive sort of exogenous shock to the system, like in this instance, a pandemic, but could be a hurricane, could be a recession, you name it, that again, the marginalized communities will be most impacted disproportionately. So once we know that, though, we have to do something about it. And I think that's where the sort of what does it look like to take efforts to achieve impact on the ground really becomes important. And what we know is that the modes of care delivery that have we've historically kind of predicated our healthcare system on don't work at addressing inequities because we've been doing the same thing over and over and over again. And receiving the same outcome. It's particularly striking when you look at some of the data on maternal health and infant mortality, where we have not closed the gap in decades of working in this space. And so what it means for us, I think, is that we have to take that data and start to think about how we deliver care in ways that really drive towards equity. That means understanding where communities need more or different tools, meeting people where they are with trusted messengers, with an attempt to start to upend the power structures and hierarchies that have perpetuated so much of this inequity, and a real humility around learning what communities need in order to be healthy. With those tools, I think with the data to measure and also the tools around community engagement and really, really building in a workforce of individuals that can earn the trust of the communities we're seeking to serve, I think we can start to move the needle.
Absolutely. And thank you so much for that, Dr. Ajayi. And that last part there around trust really just kind of jumps out at me. As we're thinking about, the kind of tools and the frameworks that we need, what sort of barriers have there been in order to get these kind of things happening? Is it a leadership issue? Is it kind of going back to the kind of programming or things that are being built into the work that's trying to be done here? What have been traditionally the barriers in order to get the things that we need to push forward on health equity?
Yeah, I can take a first stab. I think they're systemic, right? And so first is that, we haven't really cared enough to pay as much attention as we ought to have as a system. We are measured in healthcare traditionally by averages. What does it mean? You think about HEDIS measures, you think about other quality metrics. We're looking at how the average fares, and therefore you could get more bang for your buck, if you will, by moving the needle further along at the top of the pyramid, if you will, as opposed to asking what we need to do to make sure that the spread is managed. That's effectively what sort of seeking to address and understand equity looks like. So that's one piece. I think the will has been missing, as well as the measurement that ties to it. I think the second thing about trust, however, has been that our structures haven't been set up to engender trust in the healthcare system. We've been deploying a one-size-fits-all approach that is tied to physical infrastructure, where patients come to doctors and advanced practice clinicians and healthcare providers on our terms and on the sort of medical professionals' terms, and they receive sort of doses of healthcare that are doled out very much according to how we believe they should be provided, as opposed to what people want and need and what they're telling us they want and need, and we get reimbursed for that. And so the system, again, is sort of set up to perpetuate this idea that actually, whether or not the person takes the meds, whether they understand the instructions, whether they trust that you have their best interests at heart, even matter at all to whether or not you can be successful in the healthcare system as a healthcare provider. And so that structural framework has created and continues to perpetuate the outcomes that we see, and overcoming that through value-based structures of care, through community-oriented care delivery, through measurement that really focuses on equity, will start to push the needle along. But we can't expect the system to function to create different outcomes when we don't change the infrastructure and the way that it's governed and managed.
Absolutely, very well said. Thank you so much. And Dr. Powell, I know that a lot of your work has been done in the community as well. Would you care to share some additional insights on some of the barriers that you've seen in your work when it comes to addressing health equity and building those kind of solutions? Whether that's touching on trust, and things of that nature as well.
Yeah, I'm glad to chime in. I think another part here that we should consider is what our standard of health actually is, and whose standard we're comparing ourselves to. So often we've been using these frameworks that really depict, the epitome of health as being something that is middle class and really white centric. And until we really expand our definition of what that means to include everyone, I think we're still going to continue to see health inequities. An example of how we're really thinking about that in pharma is the underrepresentation of minorities in clinical research studies, right? That we are, facing a lot of challenges, and recognizing that this really is a challenge and has been for quite some time, that we're, approving medications and medical devices using a standard that really does not include everyone. And so, I think that's another way that we push against some of those barriers, and we push against those frameworks and really create more inclusion in our product development, in our clinical trials, in our community-facing and community-rooted research, all towards the goal of really trying to push the needle on health equity.
Absolutely. The aspect of clinical trials, I know, has always been something front and center, especially as we're kind of going into this world of vaccines and things of that nature. One concept, Dr. Horn, I'm not sure if you're with us right now to speak on it, but I know the concept of inclusion by design is something, particularly from a products and services piece, is at the forefront of your work and your leadership. I'd love for you to just kind of share a little bit more about what you mean or about that concept and how that can actually be embedded in the work that's happening here on health equity.
Sure, Andre. Can you all hear me now?
We
Awesome.
can. Thank you.
Awesome. Thank you for asking me that question. And it's been great hearing my colleagues and my peers talk about the amazing work that's been going on. I think with inclusion by design, we have to recognize that our healthcare system and our structural systems have excluded people of color and Indigenous people by design. So when we think about redlining, we think about our education system, all of those factors were a cause of excluding Black and Brown people by design. And that also occurred with segregation in our healthcare systems. And when we think about how are we going to do the work to erase and correct those injustices, the way that we do that is being purposeful by including the communities and the people who are experiencing what is most broken about our healthcare system in those solutions, not having them around the table, having them front and center in the way that we're designing solutions, the way that we're designing products, the way that we're designing the structure of our healthcare system and how our workflows occur. And when we start talking about data, because I am the data geek that would like to connect to the policy wonk, when we start talking about what data we're collecting, the question is, are we collecting the data that matters to people? Are we answering the question for and meeting the needs of the people who are going to be utilizing our services? And we are of service. If we are of service, it is our task to listen and to learn and understand what their needs are and measure what matters. That's really important for us to measure what matters to them, not just what matters to us.
Absolutely. Thank you so much for that. It's not, one of those things that, is always the easiest thing to do to turn around large groups of people in an industry to really kind of pay attention to what's going on here. But I think at the end of the day, we've all seen very clearly what happens when we don't take these steps to ensure that there's equitable access to care and things of that nature. So as far as just kind of next steps and what we have, I know we have a new administration this year, and something that Sachin's touched on earlier was moving from that kind of good intent piece as well. So I'd love to spend some time talking about what we can be doing right now in order to really kind of create those solutions. What kind of action steps, things around, policy making, or how do we, really tackle what's right in front of us around, accessing, the access to things like vaccinations and things of that nature as well. So I'd love for each of you to just kind of share, one or two kind of tactical and action-oriented solutions that you have in mind. And this is what Dr. Ajayi was talking about earlier, is kind of taking things into action mode. So I'd love to start off with you, Dr. Powell, around those kind of one or two takeaway items.
Yeah, thanks. I think this is so important, especially when we're talking about data. I am very biased in the sense that I'm biased towards action. So I always want to see us jump. I want to see us jump into action, but with informed decision making behind it. And so I think that there's a time and a place for collecting data. There's a time and a place and a necessity for collecting data. But ultimately, the goal should be moving beyond just quantifying these disparities and inequities to actually addressing them. And so I think that, we have to be very careful to not allow ourselves to be in a paralysis of analysis per se, and just wanting to stay in the space of constantly talking about the inequities that exist. At some point, we really need to move towards addressing them. And one way that I've seen that happen during the course of this period of time and the COVID-19 pandemic, the Commonwealth of Virginia created an equity leadership task force and leveraged data to help identify those areas across the state, those localities across the state that would be most impacted by COVID-19. In early in the pandemic, when we knew that masks and hand sanitizers were so very important, we knew we couldn't just rely on the fact that, people will just hear messaging through a radio or on TV or on social media. When we talk about, as Dr. Horn said, the need to ensure that community is at the heart and the center of addressing these inequities, the Commonwealth of Virginia really took a concerted effort to ensure that masks and hand sanitizers were distributed to the doorsteps of those who would be most under-resourced and most in need. And that is how we, leverage data, we use data, but then we put data to action. And so until we're moving from the point of just having all these repositories of data to actually moving to action, we will not succeed in addressing health inequities.
Fantastic. Thank you. Dr. Ajayi, do you have, one to two, really tactical takeaways as far as what we need to be knowing right now?
Yeah, absolutely. So I really appreciated Dr. Bishara's intro. I think the first thing we've got to do is start to really focus on building trustworthy health systems and sources of information. Some of that comes from clarity and transparency from leadership. And so I'm excited to experience that with this new administration. But some of it, and a lot of it, comes from recognizing that trusted messengers are so critical within the community, which ties into the second piece, which is around representation engaging much more diverse voices in our healthcare organizations, in our policymaking conversations, in our resource allocation decisions, really engaging folks who represent the communities that we're seeking to serve to ensure that their voices are heard, and also to ensure that they become trusted messengers for the communities with whom we have very little trust as a healthcare system for reasons that make all the sense in the world, that are totally steeped in historical experiences. And then I think the third piece is, I know you only asked for two, but my third one, which I have to harp on, is really promoting financing for healthcare and delivery of healthcare that is oriented to outcomes and not just to outputs. And that's really the trend towards and the push towards value-based care models that hold accountability for outcomes for populations that would often otherwise get left behind. Because that's the only way to really upend the way that we deliver care, is to think about how we pay for, incentivize, and administer that healthcare.
Fantastic. Thank you so much. Dr. Horn, your takeaways, please.
Yeah, no, and I think I'll add to what Toyin and Lauren have said. They're excellent recommendations. The first one that I'd say is codify what we've learned and begin to put that into place such that when this wave of media ends, that we have structural changes in place that will continue beyond this current moment. So I think it's really critical. We've been doing work on health equity for a very long time, but the challenge is that we need to incorporate that into the structures in the work that we do. The second is we need to understand that public health has been underfunded for a very long time. This didn't just occur now. And we are in a new moment when we need to think about what do public-private partnerships look like, and how do we begin to incorporate that as part of the process and part of the work of holding both our public sector and our private sector accountable for how do we change and move the needle on health equities, so that we're understanding what can organizations, but also what can the private sector do to improve health equities and health disparities. Because in addition to those people who are uninsured, we also have people who are underinsured, who are not getting health care, and we're experiencing inequities there. The next thing, and I'll add this to what Toyin said, is how do we build trusted systems? How do we build a trusted ecosystem where everyone is included and everyone's voice is heard and everyone is getting equitable care? So how are we including people in the community as part of what we're building, as part of what we're creating, and as part of the solution? How are we identifying those trusted advisors and moving them forward? One of the things that we've learned as part of COVID is how important the trusted advisor is, and those trusted sources are that we have that we tend to invite to the table, when in reality we need to be understanding how we are invited to their table so that we can learn from them and so that we can serve the community more effectively.
I love that, especially that piece around public and private partnerships, and kind of understanding the kind of roles that we have across our industry, particularly as it comes to data and policy making. Oftentimes that is not kind of the first thing that comes to mind, right? It's very kind of knowledge based. There's a lot of credentials that are out there, and when we start talking about including the community and things of that nature, I feel like one of the questions that comes to mind for me, and I'd love for each of you to share some thoughts on this, are what sort of kind of competencies and new skill sets need to be equipped for the workforce happening right now in order to make this a reality, right? And so, even, about talking and equipping with the community and creating trusted leaders, what sort of skill sets and competencies does that require as we kind of look at things from a fresh lens in order to make that a reality? I'll turn that to you, Dr. Powell.
Sure, I can jump in. And I am so glad that Dr. Horn mentioned public-private partnerships. It's just so important. As I think about, this new role, I have a Takeda focused on health equity and community wellness. And this is really a major first step for the pharmaceutical industry to really step in and assert sort of a role in helping to build health equity, in helping to promote community wellness across the country. And so I think first and foremost at the core of this, there has to be an understanding and appreciation for equity, right? That is, there has to be some internal, I think, understanding and investment in diversity, equity, inclusion, because we got to do the internal work first before we go starting to do the work on the community side. But I think, there has to be an appreciation for lived experience. There has to be an appreciation for community lived experience. I think there has to be an appreciation for the time that it takes to build relationships, the time that it takes to build institutions as being trustworthy, as opposed to putting the onus on individuals to have trust. Those are two totally different things, right? And the investment of time that it takes to build trustworthiness is very different than perhaps what we may have originally thought of as corporate social responsibility, maybe writing a check to a large nonprofit. It takes time, it takes energy, and it takes investment. It takes investment of self. And that means showing up sometimes when you're not even asking for anything. That means just being of support to the community when they need something, not necessarily when you need something. And I think those are just so important, super important competencies that I've learned myself in working with lots of different communities on the ground.
Yeah. Lauren, I'm so glad. I'm going to jump right in because there are two things that are really important. One is to listen. Going to listen, not to command the room, to be the person who's listening and learning from the community, learning what their needs are, and learning what works. One of the things that we've come to understand during this pandemic is the community and the people who were helping people get to the last mile, the community organizations, showed us what works to get people out and to get them vaccinated and to get them educated and to get them to the place where they trusted the vaccine. And the next thing that I think is humility and cultural humility, where you're sitting and learning from a community. And what you said is so key, Lauren, in going out where you're not asking for something, that you're actually there to be of service and you're actually there to learn and you're actually there to build a trusting relationship. One of the things that is really important about what we're doing with COVID is people have awareness now. And people who didn't have awareness, I describe this experience for health equity as the people who've been doing health equity for decades were in a room working in the dark. And COVID came and people who did not know that we were already there working opened the door and they said, where did all of these people come from? And we sort of said, we've already been here. We've always been here. Come join us. Well, the reality is that as time goes on, you're going to need to continue to be in that room. And when it gets dark, your eyes are going to need to adjust so that you can continue to do the work. And my thing is for people to have the staying power. When they don't get it right, when they make a mistake, to apologize, learn from that mistake, and continue to stay at the table and to continue to do the work.
Fantastic, Dr. Horne. Thank you so much. I mean, it sounds like, it is not necessarily a complicated kind of set of competencies that we need to be thinking about right now. But it really has to do with, things that we oftentimes take for granted, which is listening, and kind of powering down and opening, ourselves up to new opportunities, from people that we're actually trying to build solutions for. So it's definitely about that kind of staying power, which I really enjoy you were saying. Dr. Ajayi, did you have anything else around the competencies or kind of the skill sets that our workforce needs to understand and our leadership to make this a long-term solution?
Absolutely. I think hard to sort of follow. I mean, all those comments are just spot on. And I do think that listening is a hard competency, though I think it's not one that we get taught very well, and it's not one that gets modeled very well in healthcare. But I think the real skill that flows from this is learning to share power and learning to partner. And I think that those are two critical competencies for healthcare in this phase. We now are accustomed to seeing those charts that remind us that 80% of what drives individuals' health and well-being is actually not their diagnosis, not the medical care they get, not their genome. But we haven't learned to share power or share space or share resources with the organizations and the community leaders who are actually intervening on those issues. And actually, in fact, what we're trying to do in some ways is broaden the scope of healthcare to incorporate those capabilities in a way that may be extractive and may not actually be efficient for the healthcare system. And so learning to partner, thinking about how, as leaders in healthcare organizations, we build meaningful partnerships that are co-equal partnerships. They're not about, throwing some money to a community-based organization as part of your corporate social responsibility. It's about actually inviting them to be an equal partner at the table to co-build and co-implement key interventions for the communities we're trying to serve. That requires sharing the economics with community providers downstream and valuing their work in ways that they haven't been valued before. And that's a really important skill set and competency that I don't see us having had a reason to build in healthcare.
I love those kind of aspects around the economics and co-creation. I'm a big fan of that, especially as we talk about building with and alongside of the community. We need to also be doing so in a way that is cognizant of investing in the community as well. And so, as we wrap up here, thank you so very much once again, panel. If there's one example that you've seen, for the past several months or so of things being done properly when it comes to building an equitable future of health and really kind of, tackling these issues head on, I'd love for you to share with our audience.
Yeah,
Dr. Horn, I'll turn that over to you.
Yeah, no. So I just want to, as they often say, I just want to +1 the importance of economic empowerment of communities because, health is wealth. And we need to, in addition, as healthcare systems, share in the economic empowerment of the communities that we're trying to serve, because that is going to be critical for them to attain their health as well. So supporting those minority-owned businesses, supporting businesses in the community as our vendors as part of the work, because when we're giving people jobs and we're giving people employment, we're having the opportunity for allowing them to be self-sustaining within their communities. So I think that's really important. I think one of the things that I've seen as an example, and I'll give a really local example from a personal perspective. When the COVID vaccine came out and it was available, I'm from Mississippi. I'm from the Deep South. The way that the local community in my hometown of Jackson, Mississippi, was able to outreach and get to the seniors in the community who did not have community access, who did not have the ability to register, was they went to the local churches. And the churches outreached to every single senior that was eligible to get the vaccine. They educated them, and then they signed them up, and they made sure that they got there, because we can do this amazing innovation and get a vaccine out in record time. But the importance of this vaccination is getting the vaccine in the arm. And those trusted sources were able to not only reach the community, educate the community, but through their trusted resources, get their community seniors vaccinated who didn't have the capacity to sign up online. So I think it's really important for us to understand how important those last mile organizations are in bringing and building coalitions to do that work across the country. So for me, that's just one example in a community.
Fantastic. Thank you so much, Dr. Horn. Dr. Powell, did you have one quick example for us?
I'll just underscore, I think my example is very similar to Dr. Horn. So I'll just underscore sort of the necessity, again, to really uplift community voices and uplift the fact that communities already know how to solve many of these problems we're kind of trying to throw solutions at them for. So I just want to further underscore that, and the precision and care in that example, Dr. Horn, just that's another level of data, right, that we should be collecting, that we should be uplifting, and we should be applying.
Fantastic. Dr. Ajayi, please close us out.
Sure. I will give a shout out to physicians of color. Particularly, there's been a really incredible group of Black women physicians who recognize that representation matters a tremendous amount, who have been really courageous and outspoken and honest and vulnerable in talking about their experiences with the COVID vaccine and using that as leverage and as an opportunity to engage in real conversations with communities of color and partnerships with communities of color. I think about Dr. Uche Blackstock, Dr. Kimberly Manning, Dr. Alice Stanford, and the work she's been doing in Philadelphia with churches and getting folks out. We know, as you know, the few of us that there are, physician leaders of color in healthcare organizations, that we have a real privilege and an opportunity to speak to our community, to speak to people who look like us in a way that that holds weight and credibility and the potential for trust building, even as we operate as part of a system that has not always earned the trust of the communities we seek to serve. And I've been really inspired by folks who are engaging and leaning forward into this privilege and this opportunity as trusted messengers for a community that doesn't have very many to look towards. So wanted to call that out as a real moment of hope, and also, you know, to folks who are leaning on their physician leaders of color to do this work, recognize that it is tiresome. It's hard. It's an additional tax on all of us who are just doing our day jobs. And so I really would encourage the leaders who are listening and watching to create space and to value that work that they see their colleagues do, particularly their colleagues of color do in a moment like this, and recognize that it is really impactful, but it is also work, and that it needs to be supported. So thank you.
Absolutely. Thank you so very much, each and every one of you, for the time today to talk about this very important issue, as well as kind of how we can get started or continue doing the work that needs to be done. Let's get to work. Thank you.